Hello everyone. Welcome to another webinar from the Steps Forward Innovation Academy. Today, we will be discussing best practices for implementing a new EHR system or transitioning from one EHR system to another. Some quick housekeeping items before we begin. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of this posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. Okay, so I am delighted to introduce our presenter today, Dr. Seppo Rinne. Dr. Rinne is a pulmonary and critical care physician, a board-certified clinical informaticist, and a health systems researcher with joint appointments as associate professor at the Geisel School of Medicine at Dartmouth and core investigator at the VA Bedford Center for Healthcare Organization and Implementation Research. His work is focused on the intersection between clinical informatics and implementation science. He is particularly interested in how technology can facilitate learning health systems through data capture, analysis, and evidence-based practice improvements. In his current work, he is applying these principles to lead several research and evaluation projects at the VA's electronic health record transition from a homegrown legacy system to a new commercial EHR. His research and evaluation efforts have been instrumental in identifying improvement opportunities that have informed EHR transition efforts and impacted VA policy. He was recently granted a VA Health Service Research Health System Impact Award in recognition of the profound and positive impact his work has had on VA and veteran care. His overarching career goal is to continue efforts that support technology implementation and facilitate evidence-based practice improvements. Okay, so without further ado, I will go ahead and hand the microphone over to you, Dr. Rinne.
Awesome. Thank you so much. I am really excited to be here. I think this topic is impactful, it's important, and it's interesting. There are a lot of challenges and nuances in EHR transitions that we'll address today, and hopefully impart some wisdom that can be used at future EHR transitions, especially as technology continues to evolve. We have a few learning objectives, and hopefully we'll be able to see how the presentation flows through each of these. The first is to identify ways to prepare health systems for EHR transitions in the pre-go live period, understanding what kind of preparations and planning needs to happen, anticipate some of the potential negative consequences that emerge during the transition, and identify strategies to mitigate those negative consequences. We're also going to discuss how to support continued optimization and training and support after go live. EHR transitions are common, they're complex, and they are costly. First generation EHRs are now giving way to newer systems where earlier EHRs were designed oftentimes as homegrown EHRs or niche EHRs that addressed specific clinical functions and required multiple different EHRs to be tied together. Newer EHRs centralize this and create a more kind of unified EHR that can address diverse clinical needs. It expands functionality, and what we've seen is over time, those first generation EHRs are giving way to these very few consolidated EHR systems. So Epic, Oracle Health, or formerly Cerner, and Meditech own the vast majority of the market share, almost 90% of the market share of EHRs. And while the health systems that are transitioning to new EHRs generally adopt one of these three systems, the experiences vary considerably, even for those systems adopting the same EHR, which implies how we implement the EHR matters. This is not a simple transition. It's not moving from a PC to a Mac. It involves every aspect of care delivery. It involves the clinical workflows, how you deliver care, the relationships that you have in a healthcare setting, who do you interact with to help support and provide care. It involves all of the routine management and processes for patients. It is a massive undertaking that really transforms the organization and the culture. It's not just a technology implementation. these can also be really expensive. The technology itself is expensive, the change management is expensive, and so it's important to get it right as we implement the new HR. I also want to just call out the important implications for new technologies. We intentionally decided not to integrate AI as a focus of this webinar, but EHRs are advancing at breakneck speed. The EHRs that we have now are going to be wildly different in even just a few years. And it's important, the lessons that we learn today with previous EHR transitions can inform how we do it better moving forward. So how can we learn from experience? A lot of the information on EHR transition or the guiding recommendations come from initial EHR implementation experiences. So sites that moved from paper to EHRs, to the first kind of digital experience. And that has its own unique information, certainly that informs a lot of the presentation today. But it is different to move from paper to an EHR than moving from an EHR to an EHR. So moving from one EHR to another requires systems to unlearn established practices before learning new practices. So while that's important information, it can't be the only guiding light. We do draw from prior EHR transition experiences. There is a growing body of literature on EHR transitions across health systems. Much of this literature is single site, pre-post studies with very limited empirical data, virtually no interventional studies to help us inform how we do this better. And so we draw on a lot of informatics and implementation science frameworks, some of the guiding principles of socio-technical systems that, again, this is not just a technology change, but involves all of the surrounding social constructs, the context, the organization, and important change management. What are the lessons that we can learn on how we inform and teach and train and support organizations undergoing EHR transitions? We applied these diverse data sources to develop 9 key steps to achieve a smooth transition. Achieving a smooth transition requires careful planning, coordination, and preparation across 3 core stages of implementation: the pre-go live period, the go live, and the post-go live. Each of these phases plays a crucial role in supporting the EHR transition, and there are unique steps for each of them. Prior to go live, it's critical to set up the planning and preparation for the go live and anticipate any potential negative consequences. During go live, it can be a really stressful time, and it's important to support the individuals undergoing the go live and actually launch the system. And then post go live, it's a period where we can assess for feedback, could gather information to improve the EHR transition and improve future care. So I'm going to go through each of these steps and we'll have time to reflect and bring it all together at the end. Our first step is creating an EHR transition team. This may be the single most important step. Creating a EHR transition team is an essential foundation. It includes a broad and diverse group of partners. So that could be everyone from the C-suite to clinical end users. It can include the EHR vendor, and it can include informatics, clinical operations, business operations, and administration. Engaging this broad and diverse group of individuals helps ensure that the EHR transition is relevant to end users, that we can get the end user's voice, and it helps ensure that the planning and preparation anticipates all of the potential challenges. It's critical to ensure that there's adequate knowledge and skill, that not everyone who is tapped to be in this EHR transition team has the foundational knowledge that's necessary. So sometimes you need to train up, that you need to give people the change management training, the information knowledge and skills to be able to execute in that role. I've already mentioned this once, but I don't think I can mention it enough. You have to engage end users. End users are the people, the physicians, the nurses, the staff that will be using the system and can help relay some of the underlying cultural challenges, the resistance to change, and help feedback on some of the problems or difficulties that emerge during the EHR transition. So end users are really key. You need that multidisciplinary approach where all voices are heard and are relayed and are able to kind of communicate and support the EHR transition. And I did mention the vendors. This is really critical. I think oftentimes we think of the vendors as kind of the a source of at times conflict or differing opinion. You may not have the same perspective or the same underlying goal, but the reality is EHR vendors want what health systems want, and that is to develop and implement a system that works for that health system. So figuring out how you can best work with the partners and engage them in the transition process is key. Once you have established the EHR transition team, you need to communicate with end users and gain buy-in. This is one of the most fundamental steps. Be clear on why the transition is happening. As an organizational leader, it's important from the outset to reflect on some of the issues that are prompting the transition from maybe whether it's an old, outdated technology, whether there's need to improve care coordination or enhance efficiency. Be transparent and be realistic with the goals and challenges that people are gonna experience. This is maybe saying the obvious, but when team members feel that the current EHR isn't meeting their needs or their goals, they're more receptive to moving to the new EHR that has perceived better value. So in other words, giving people a reason to change matters. You also need to establish a broad communication strategy. Communicate frequently and thoroughly through multiple challenges, emails, internal messaging, town halls, team and department meetings, and even walkarounds to get some of that face time with frontline clinicians. Very few end users who have undergone EHR transitions reflect that there was too much communication. Oftentimes it's the opposite, that end users feel that they could have learned more and heard more about the transition. It's important to streamline and offer direct information about where to go for that information. But being upfront, being honest, and being openly communicative is key. One key principle here is also to be transparent. What we'll discuss today is that these EHR transitions are incredibly complex, they're challenging, and they can be painful. And there's a natural need to kind of voice some of that and feel heard, that these are difficult experiences, and you want the leaders to hear and have empathy for the transitions that are happening. The next step is to decide on an implementation approach. And this is a really interesting slide for me because, oftentimes in medicine, we've developed clear practices that are all the norm. This is how things are done, and it's just one way. And when you think about an implementation approach, there are two kind of extremes that we'll discuss. One is a big bang approach where everyone goes live at the same time. You can think about it like flipping on a light switch. On the other end of the spectrum, there's a phased rollout where one site or one department or one clinic goes live at a time, which allows for more of a test the waters approach. And both of those are happening now. And the reality is there may be some in between that's appropriate, that maybe there is some testing the waters, but there's also a role for going live all at once you have the system that is more stable. There are pros and cons to each of these approaches. So for the big bang approach, there's a pro that you get to engage all the departments as once. There's less time maintaining two different systems. You can basically rip the Band-Aid off and get everyone onto the new system as quickly as possible. So it reduces the time for the transition. Having said that, it can be a really stressful time, at least for that period where everyone's going live. And there's limited opportunities to learn from the early experiences if everyone's going live at once. In contrast, the phased rollout has opportunities to, again, test the waters. It identifies pain points early and is able to make potential modifications. you can also isolate catastrophic issues so it doesn't impact the entire health system or doesn't impact the entire patient population. You're able to identify those difficulties and improve them. And then there's this opportunity to use a pay-it-forward model, wherein individuals who've gone live in early sites are able to support and help those at later sites. We're going to come back to that concept through this presentation because it's such a valuable tool. That all being said, the phased rollout also has its challenges. It's costly. You're maintaining 2 different EHRs at the same time. And that cost is not only a financial one, but is also an emotional one, where people are not fully committed or engaged in any one kind of organizational change, that they're still trying to balance both of these EHRs and still balance the associated workflows and norms that may exist across the health system. Then, we use a phased rollout because we think that the early experiences are going to inform later experiences, but it's entirely possible that the later experience are still going to be unique. So we may still be learning things at later sites where there are unique healthcare delivery and unique organizational factors that impact the EHR transition. So it won't predict all issues. Okay, on to step 4. In preparing for an EHR transition, it is essential to understand the current state of the EHR. And that sounds like, it's pretty self-evident. And maybe a lot of you would assume that, yeah, of course, if you're going live with a new EHR, then you start by understanding where you're coming from. But this actually doesn't happen all the time. And when we've done multi-site qualitative studies, we've seen a huge amount of variation across systems. So some health systems absolutely embrace and put attention to understanding their current state, and others do that less. And even within the same health system, there's variability. So one emergency clinical lead was able to really weather the storm at their EHR transition in a way that was vastly different. They have much better experience than the other clinical services at that same site. This stage allows us to uncover inefficiencies and identify areas for improvement. So an example of that was that there was a site where whenever a specific radiology order was made, they would actually print out a piece of paper and they would have to run it down to the radiologist. So this tremendous inefficiency, this is not that long ago that they were relying on a workaround that was antiquated and inefficient. And understanding those inefficiencies allows you to prepare better for the EHR transition and make sure that things are more streamlined. It also allows you to understand current user roles. So when we think about, just as background, modern EHRs in general are role specific, which means the EHR system, the interface and capabilities differ from role to role. A critical care physician may have different capabilities and EHR interactions than a social worker, outpatient social worker. And so the EHR reflects those different roles. You need to know what are the current state roles and where are there opportunities to anticipate kind of future needs. And a couple of examples of that are that one EHR system inadvertently created roles where nurses were able to prescribe opioids, which is obviously inappropriate, and they had to really backtrack and reevaluate how they were designating roles. Another example of the importance of identifying roles is that there was a health system, a DoD health system, where they looked at kind of the future state needs of the new EHR, and they found that the real bottleneck was not in the provider or physician time, it was in the medical support assistant or scheduler time, that those were the people who were requiring a lot more ramp up in the post-go live period, and they needed to accommodate that by hiring up for that role. Step 5, consider customization needs for the new EHR. This was probably the hardest slide for us to put together and the hardest concept because it's really nuanced. When you're implementing a new EHR, some customization is necessary. There's a reality that every health system is unique and they have their unique needs. in an extreme sense, I work for the Department of Veteran Affairs, and we have a pharmacy service line. Most hospitals do not have a pharmacy integrated into their healthcare system. So as we're integrating or implementing a new EHR, we need to customize it to be able to deliver pharmacy care. So it's a new customization that is required. That being said, it's important to strike the right balance. Customization should support functionality, should address the local needs, but too much customization is risky, and it can create problems. It increases the time to go live, so basically requires a lot more effort and energy on the front end to try to create an EHR that is customized to the specific healthcare system. It increases the costs because of the associated technical time and focus. It becomes more difficult to implement. There was one site that said it was so customized that even the help couldn't help us. And they were referring to the vendor-led help, the EHR-led help didn't really know the EHR anymore because it had been customized beyond their recognition. So customization is important, but it also has a little bit of a double-edged sword. And I guess one additional reflection on customization is off-the-shelf or out-of-the-box EHRs have the advantage of being tailor-made to function. And when you disrupt some of those functions, you can think about it as a gear in a machine. You take out one of those gears and put it with another, it affects a lot of the other kind of interfaces with the other workflows. And so system upgrades are more difficult, and it could break some of the core functionality that does exist, or the advantage of the off-the-shelf EHR. So all of that's to say, this is a tricky thing to say. Customize when needed, but maybe consider not customizing or avoid overly customizing, and recognize the importance of optimization after go live. Step 6, anticipate challenges. I struggled not to know how to display all of this information because there are a lot of challenges that can emerge with an EHR transition, and they range from the individual staff morale to a lot of the technical data and security issues. Recognize that these challenges emerge and anticipate and avoid them when possible. We'll talk a little bit about the stress and dissatisfaction that emerges during EHR transitions. This is a really difficult time, and it's difficult not only because you're learning a new EHR and that's totally disrupting the way you provide care, the way you conduct your day-to-day, the relationships you have at work, but also because it can create an anxiety about what's the impact on patients. As you're transitioning to an EHR, there's an unknown. You don't know if you're working with the EHR to the best of its capability. You may have some safety concerns about the new EHR. And in doing so, we've had some respondents who've kind of labeled this as moral distress, that you know the care that you want to deliver, but you're impaired to do so because of an EHR that you're either unfamiliar with or itself has its own safety risks. So it's a stressful time. Recognize that, create a well-being task force, and avoid additional stressors. We'll talk more about that in subsequent slides. Personnel resources can be a major challenge. A lot of the end users are diverted to support the EHR transition, to help with go live, to help with training. And it's critical to recognize that you're not going to perform at the same level of productivity, that there's going to be a lower level of productivity. And that lower level of productivity may last a while. Typically clinics are at reduced capacity for a couple of weeks after go live, but it's possible that this will last months or even years. And some systems never get fully back to their baseline level of productivity. So recognize that this is a challenge, accept that lower productivity, and selectively hire short-term staff or use this pay-it-forward model, where some of the early EHR transition clinicians can go to future sites and offload some of the clinical demand and support with the training and education. There are challenges with workflow redesign, customization. We've talked about that. Some of the data migration, risks for data loss and breaches, cybersecurity concerns, risks for intrusions. A lot of these require tailored data management teams and cybersecurity task force. So anticipate these concerns and develop a plan to try to mitigate them. Step 7, offer training and support. This is one of the areas where health systems can make a difference. Formalized training through didactics can help give an initial exposure to the EHR and help people be prepared for it. And oftentimes that really, not oftentimes, it always needs to be complemented by at-the-elbow support, where people find that level of personal contact and troubleshooting better and more effective, more helpful than some of the didactic and lectures. Oftentimes, the training that happens in classes is kind of a go here, click this, go there, click that. And it's oftentimes labeled as a buttonology, trying to understand where the buttons are without really fully understanding how it helps you provide the care that you do. So to the extent possible, try to tailor that training to make it more dynamic, to address the actual clinical workflows and make it effective for the people who are being trained. The reality is most health systems, or oftentimes health systems, will lean to vendors or third parties to do the training, consulting groups. But the truth has been across health systems that having internal support, having clinicians that know the health system lead the training is most effective. And recognizing that that's an additional cost, it takes them away from clinical care. But consistently, we've heard that has been a more effective way at helping end users learn the new EHR. Step 7, mitigate other workplace stressors. We've already talked about this, but I guess I can't say enough that this is a challenging time. Recognize that it's a challenging time and support end users. And some of that is adapting the clinical workflow, like we've discussed, with the workloads that people are not feeling overwhelmed during this, during the EHR transition. Some of it is avoiding concurrent organizational initiatives or other stressors. One of VA's first EHR transitions happened at a site that was also experiencing an early COVID surge, which created a lot of challenges with managing these two major competing stressors. So recognizing that those challenges can happen, and to the extent possible, planned organizational initiatives should be delayed. Also consider how to best support clinician well-being. So finding ways to listen, to help them feel heard, and also to establish strategies to acknowledge the stress and burnout. Some of this may be wellness initiatives, but recognize that wellness initiatives can add additional expectations or work. Yoga classes may not be possible if somebody is already just juggling so much during the EHR transition. So kind of tailor that to the local need. And our final step, gather feedback and support ongoing optimization. I guess this is probably, in my opinion, one of the most important steps that we could offer. And the reason, because EHR transitions are an ongoing process. There's going to always be new developments and technologies that will require the system to adapt and improve. And so recognize that this is a journey and invest in that journey. Recognize the value of some of the continuous improvement efforts, the plan, do, study, act type initiatives that can hear some of the early feedback and improve both the system, optimizing the technology, and support ongoing training and support. So figuring out how to create this ongoing effort that doesn't end just after the vendor leaves and the go live period is done. So we talked about a lot. I'm excited to go into some of the questions that will come up, but I do want to go over a couple of key pearls. One is that relationships matter, and that we talked about that in the context of a transition team, that having robust relationships across the organizations with leaders and end users, with the EHR vendor, creates a system that can help anticipate challenges and support the organization as they go live. I talked about planning to customize, the importance of this being sometimes labeled kind of a double-edged sword. There's a value in customizing, but there are also challenges, and recognize that that duality and the need to kind of adapt, but not overly customize will be key. The vendor and training support will help, but developing local approaches with internal staff tends to be better. And so this is one thing that is, again, costly and can be time intensive to take away the clinicians to do some of that training and support, but it's worth it. And I alluded to the pay it forward programs that have existed in many healthcare systems, were prominent in the DoD and are currently being used in VA. And they're rated some of the best initiatives to support the EHR transition. So valuing that is critical. And the last thing I'll say before we go into a question period is this is not only an ongoing process for existing technology, but we live in a really exciting era for EHRs where technology is developing really rapidly. I have no doubt that there will be many AMA discussions about integrating AI into healthcare, and there should be. But the principles that we've talked about today are just as applicable for integrating AI and innovative technologies as they are with current and existing EHRs. So this is, in many ways, I know this is a very self-serving thing to say, but maybe one of the most important things that health systems can do is learning how we better integrate technology to facilitate higher quality care, more efficient care, safer care, and care that values the clinician and the clinician well-being. So I'm gonna pause there and maybe we can go into some questions.
Wonderful. Thank you so much, Dr. Rinne. That was a very excellent synopsis of a very complex topic that you've really managed to distill down into very useful practical steps. So we had some pre-questions that came in, and then please feel free to continue to enter any questions now live. I'll just start off with one of the pre-questions that just touched on your personal experience at the VA. I think people often remember those personal experience anecdotes the best. Were there any specific, I know this was, again, a huge project, huge undertaking with many layers of challenges, but are there any key lessons that you learned from the challenges that you experienced at the VA? I know some of that was covered in the pearls at the end, but any specific anecdotes from your personal experience?
VA, so just for those of you who are not aware, the Department of Veterans Affairs is undergoing a massive organizational change from a legacy EHR, one of the first EHRs in the world, and really, in general, a really beloved EHR, to a new commercial EHR by Oracle Health, or formerly Cerner. And I think there are a lot of reflections, and would be happy to connect with anyone who's more interested. We've published several papers on this, and we continue to support VA leadership the best we can to identify best practices to improve. I think that distilling it down to a few lines is difficult, but what I will say is, number one, this is a massive undertaking. It's the largest EHR transition in the world, and VA is a unique environment. So there are challenges that emerge just because of that. There are also very unique characteristics. I alluded to kind of the pharmacy needs. There are other unique elements that need to be addressed, and I think some of the effort that we've been trying to support VA leadership with is understanding how the change management can evolve and improve. And some of that is in communication. I reflected on a lot of the communication needs during an EHR transition. We have seen a lot of progress in the VA where there's been much more concerted effort at supporting kind of why are we undergoing an EHR transition? What's the need to undergo the EHR transition? And the consequence of that is we've seen a lot more people accept and be receptive. I've mentioned a lot of the training and support, and I think we are learning lessons. We continue to learn lessons. Right now, I'm actually down in Orlando at the Simulation Center, where we've seen a lot of benefit from just early simulation of the EHR transition in a way that allows people to prepare and have a better EHR transition experience. So being able to take those types of lessons and apply them in a more large scale way is key. But this is a learning, it's a learning process where we're continuing to try to improve, and there are continued opportunities to improve.
Thank you, absolutely. Okay, another question that's come in is, can you address how small rural practices might address some of these issues, since they are often quite limited in the resources they have to use?
Yeah, that is really difficult because you can think of the VA's EHR transition, for an example, on the other end of the spectrum, is estimated to cost more than $30 billion. It's a massive undertaking, and it requires a lot of that kind of focus and attention. And I don't want to discount the reality that this is difficult, and it would be difficult with less resources and attention in smaller sites. Having said that, I think the same core principles apply. You need a transition team. You need a communication approach. You need the additional training and support that can best facilitate a go live. And applying these lessons, while they may be more challenging, are still very much applicable. I think it may require digging a little bit deeper to find the people who could be the super users and the change agents, and working cohesively to make that change. I will say there's a flip side, and that is that some of these smaller sites have a closer and more cohesive culture and are able to weather some of these transitions more effectively. So I don't think there's anything unique that I would do, but I think, and I guess that's the point, I think a lot of these same principles apply.
Excellent. Okay, so another question that came in, which I'm kind of not exactly sure if it's the right, what the question is specifically asking, but maybe we can, if you don't, we could further clarify if needed, but how to think about integrations in EHR and trade-offs.
I'm guessing that refers to multiple EHR integrations or additional applications that overlay EHRs. And I think the question is, if I interpret it right, I think it is really insightful, and partly because a single EHR, as much as kind of newer generations EHRs try to do everything, they simply can't, and maybe they shouldn't. Maybe we should have innovations that can integrate and allow for additional clinical decision support or additional data displays that can improve care in unique ways. It is a trade-off, and I think it, just as much as everything I said about customization, it totally applies here. I think we need innovation, and a lot of the new AI tools are built as add-ons, but at the same time, they need to be evaluated, assessed, and improved. And when you do have that kind of integration process, there's a risk that there's inadequate integration or not fully integrated, and creates more challenges. So I think the short answer to that question is, I think you do so carefully, judiciously, and as an evaluator, what I'll say is one of the most important principles is embrace the idea of being an evaluator, understand how things are working and how they're not, put the time, energy, and effort into assessing kind of what the impact is, and make further refinements.
Got it. Okay, that makes sense. That's very helpful to me. I think from the end user experience, we probably don't appreciate all the integrations that occur when within our main EHR. I think we just think of it as one EHR, but that makes sense what you're saying. There's probably all these add-ons that are separately integrated. And actually a follow-up question has, when someone's saying that they attended a recent AMIA conference that was specifically where many exhibitors were talking about being integrated into Epic. And the question is, how more specifically is the integration done typically?
Yeah, that integration, I'm not an expert on this. I think there are various ways that those technologies can integrate depending on the technology, but I do think the underlying principle of the impact on clinical care relates in many ways to kind of my response earlier, and that is that you can have all of the planning and preparation in the world to try to anticipate the clinical impacts of a new EHR, if you're transitioning to an EHR, and or some of these additional applications. But you really do need to monitor and improve. It's the very reason that a lot of health systems embrace this phased rollout approach, is because it allows that initial testing water, see how things play out, and for further refinements. But this is, I can't say enough, this is such an exciting time in healthcare, partly because the technology is evolving really rapidly and allows us to do incredible, amazing things. But there are risks and consequences of that. And it's up to us, probably many of the people on this webinar, to be the voices that drive and ensure that we are doing so in a safe, effective, efficient way, that we're not compromising clinician well-being, that we consider this, again, as a journey that we learn from without just embracing new technology for technology's sake.
Yeah, I think that's such an important point about technology as a larger topic. And I know, in discussing within the AMA, our Vice President of Digital Health, Dr. Margaret Lozowatsky, I just hear her always saying that we need to design the technology to fit our clinical workflows, not vice versa. Oh my gosh.
Yeah, no, spot on. I think there's so much, and there is a narrative that EHRs were really designed for billing. I'm not sure that's entirely true, but I do think that the clinician voice has suffered in healthcare in many ways, that we're not always the people who are driving care improvements, that sometimes those even feel imposed. And especially technology is a tool, right? And tools should make our lives easier, not harder. And when the opposite is true, something's wrong. And unfortunately, I think EHRs oftentimes cause more burden and more burnout, and require, careful consideration to make sure that we're both implementing them in the most effective way and using them in the most effective way.
Right, exactly. Because as physicians or nurses or other, I think it's just our natural instincts. Oh, we'll adapt our workflow to do what the technology wants, and that is the tail wagging the dog, right? So it's
the people who are printing off the radiology recommendation, then walking it down several floors, because it's just kind of that adaptation. But these are the right questions, and I think it's up to us to be that voice to make sure that these systems are the best that they can be.
Yes, absolutely. Well, I think that is a good note to end on, and I will just, Alec, if you don't mind, I'll pass it off back to you to make the closing comments regarding more housekeeping items. Thank you all for attending.
Absolutely, no problem. Thank you, folks, for your time and joining us today. Thank you to Dr. Jill Rinne for your time and expertise today. We just have a couple things in the pipeline that we thought some of our wonderful attendees might learn more about here today. We have an exciting new program here, the Learning Collaboratives, where participants will commit to attend 4 to 6 physician-facilitated web sessions over several months to execute system-level changes and measure their effectiveness wherever you're working. So registration for our upcoming topic on AI governance begins on December 1st, and the program will begin in April 2025 and run for several months. If you have interest in attending, scan the code on the right side now, or click the link in the resources widget on your console. Also in that widget, you'll find today's slides and other suggested content from today's discussion. We've added a selection of our Steps Forward podcasts related to today's topic for your convenience. For additional resources to support your physicians and staff, please visit the American Medical Association website or stepsforward.org. And you may have noticed a survey widget in your console. Please take the time to answer the questions there. Your responses help guide our upcoming programming and deliver the webinars you want to see, such as the one you saw today. You can register now for any of our next webinars at the Innovation Academy by following the link in your console. And that is all we have for you today. So thank you again for joining us, and we hope to see you soon.